Okay, I'm going to start with the introduction. Welcome to Beyond BRCA Mutations, What's New in the World of Genetic Testing. My name is Savannah Shine, and I'm here with my colleague Christine Benjamin, and we're here from SHARE. I'm the Ovarian Cancer Program Director, and Christine is the Breast Cancer Program Director. Before the presentation begins, I'd like to just tell you a little bit about SHARE. We are a 40-year-old nonprofit organization that helps people through breast or ovarian cancer. We offer support of those who've been there. We offer various services, including a helpline staffed by survivors, telephone and in-person support groups, and educational programs like this one. All services are free, and please do visit our website for more information. It's sharecancersupport.org. A little bit about this webinar. All participants will be muted during the presentation. You are welcome to submit questions throughout the presentation. You're going to look on the right side of your screen at the control panel. There's a question pane. You can click on that and write your question in there. And at the end, after Dr. Robson presents, we will submit the questions to him one by one. And again, this webinar is being recorded. It will be available on the SHARE website later for anybody you know that wasn't able to attend, or if you want to listen to it again. Now I would like to introduce our speaker. I just want to check with my colleague Christine. Yes, it's being recorded. Okay. So I'd like to introduce our speaker. Dr. Mark Robson is an Associate Attending Physician of Clinical Genetics and Breast Medicine Service in the Department of Medicine at Memorial Sloan Kettering Cancer Center. He's also the Clinic Director of the Clinical Genetics Service and the Chair of the Cancer Genetics Subcommittee of the American Society of Clinical Oncology. His research focuses on the identification and management of individuals who have an inherited and increased risk factor for cancer. I'd like to turn the presentation over to Dr. Robson. And thank you so much again.
Well, thank you for having me, and thank you all for joining on this summer afternoon. I'm going to spend a little bit of time just doing an update of some aspects of our understanding of inherited risk for breast and ovary cancer. Obviously, this is an expanding topic, and there's an enormous amount of information that's coming in on a monthly basis, and I won't pretend that this is comprehensive, but hopefully if there are specific questions or issues you want to address during the question and answer period, we'll be able to do that. The story, the history of all this is actually pretty interesting, and I always enjoy going through it just because it's fun to think about how recent most of our understanding of this actually is. I mean, the first observation of familial predisposition was probably back in the mid-1800s by this fellow. He's a guy named Paul Broca, who was a very well-known French pathologist who described a family in which there were multiple cases of breast cancer and what we think in retrospect are probably gynecologic cancer and most likely ovarian non-specific abdominal cancer. Paul Broca was actually Jewish, and it's probable, although that isn't necessarily dispositive, but it's probable that he was the first description of a BRCA family, which happened to be his wife. But things kind of languished after that. There's an observation that there was a lot of familial aggregation of cancer, but there are other potential explanations for that. A lot of times you'll see more than one case of a cancer in a family just because of chance, particularly if the family is big, the cancer is common, and people live to an older age. It's not at all unusual to see several cases of the same cancer. For instance, you see two 80-year-olds with breast cancer. People usually aren't thinking about genetics. They're just thinking it's a common disease and people live to a later age. Shared environmental factors are not necessarily so important for breast and ovarian cancer, but lung cancer, if you see more than one case of lung cancer in a family, you're not usually thinking about whether or not there's a shared gene. You're actually thinking about whether or not they all smoke, or perhaps they all live in a radon-contaminated area. Shared sociocultural risk factors are kind of an interesting thing to think about. For instance, later age at first childbirth we know is a risk factor for breast cancer. Tends to be associated with higher socioeconomic status, and that, of course, also tends to be shared among different family members. So that is one reason why you might have an increased risk among a family that doesn't have anything to do with genetics. But of course, we are here to talk about genetics. And this is a relatively recent idea. It's so much a part of the cultural landscape now that it's perhaps a bit surprising. But back in the 60s and 70s, there was a real push towards considering cancer in general, including breast and ovarian cancers, as being environmentally caused diseases, and there's a lot of interest in viruses in particular. And the concept that something could be due to an inherited mutation, that something could be passed along like a childhood genetic disorder, was really quite beyond the pale, and was thought to be kind of a fringe type of belief. That all changed in the 1970s and 1980s. The fellow on the left is Henry Lynch, who is actually very well known for just straight-up clinical descriptions of families with multiple cases of cancer. And although he's best known for colon cancer, the Lynch syndrome, he was actually the first to recognize that there were families that had breast cancer and ovarian cancer within them. The woman on the right is Mary Claire King, of course, and she was the first to begin to apply statistical techniques to show that you could explain certain aggregations of cancer by positing the presence of a gene that was rare, but that was quite strongly predisposing if it was abnormal. And this was now mathematical, scientific, and statistical proof. But we didn't have the tools at that time when they were first describing these families to go and find the genes. But what they were finding, what they were describing, was what we call autosomal dominant predispositions. And autosomal dominant predispositions, this is a pedigree on the left. Men are squares, women are circles. The folks colored in orange are people who have had a disease, in this case either breast or ovarian cancer, and lines, unfortunately, mean that they're deceased. And generally, autosomal dominant predispositions are those in which there's early onset of a disorder. If there are paired organs, the disease can occur in both of them, so two breasts, two kidneys, for instance, because the same predisposition is present in both. Males and females can transmit the disorder equally well because it's not on a sex chromosome or a gender-determinant chromosome. It's actually on one of what are called the autosomes, which are the non-sex chromosomes. But oftentimes, what we call penetrance is incomplete. In other words, somebody may have the mutation but not necessarily develop the disease. So in this particular case, this woman here is presumed to be a carrier of whatever the mutation is because this woman had it and this woman has it, so the only way it gets from here to there is through her, but she hasn't had the disorder. And lastly, depending on what the predisposition is to, you can have gender variable expression. So in BRCA or hereditary breast and ovarian cancer, men aren't going to get ovarian cancer, women aren't going to get prostate cancer. And so depending on what the predisposition is, it may be masked within a particular family. So here, for instance, if you didn't know about this part of the family history, if all you knew about was this part of the family history, this woman inherited her mutation from her father. Her grandmother has it, but was non-penetrant. And so something could have come down now through 3 generations before it declared itself because of all these different factors that can hide or mask an autosomal dominant risk. So in 1994, finally, BRCA1 was cloned, was identified, because the technology did evolve to allow us to do that. And then in 1995, BRCA2 was identified. And now we've had 22 years worth of working with these genes to try to figure out the best way to manage them. It's become part of the cultural landscape. It was already really moving very rapidly into clinical practice, but then Angelina Jolie's disclosure in 2013 kick-started things, and now there's a very broad understanding or broad approach to genetic testing for BRCA, and we're figuring out that it's the most common cause of autosomal dominant predisposition to breast and ovarian cancer. And it may actually be more common than we thought. There's some recent work suggesting that maybe 1 in 200 individuals of European ancestry wind up having a BRCA1 or a BRCA2 mutation. It ranges in different groups. Some of the increase in the European group is due to the well-known risk in individuals of Ashkenazi Jewish descent or Eastern Central European Jewish descent, where it's about 1 in 40. But even in non-Jewish Europeans, it may be up to around 1 in 300, which is not a small number for a genetic disorder. It seems to perhaps be a little bit less common in women of African descent, but there have been much fewer individuals tested to really hammer that down. So the number of 1 in 800, which you sometimes read, is probably a bit too low. And among Europeans, it may be, like I said, 1 in 200, 1 in 300, and it's 1 in 40 among Ashkenazi individuals. So that has a couple of implications. One is obviously that it gives some impetus to the conversation that people are having about doing population screening. And the other is that it may mean that the risks that are associated with the genes vary, and that if you did do population screening, the risks would be lower, because it doesn't look like 1 in 200 is the number that we're getting when we actually test individuals in the clinic. The risks are well known, though. Breast cancer risks range from 50 to 80%. The interventions are breast MRI or preventive mastectomy. Ovarian cancer, it's from 15 to 60%. BRCA2 is lower and later than BRCA1. The standard intervention so far has been risk-reducing salpingo oophorectomy, which means tubes and ovaries. Recently, there has been some suggestion that there might be, in some subsets of patients, an increase in risk for particular types of uterine cancer. And although the absolute risk is very, very low, and it may be restricted to women who have been exposed to tamoxifen, there's an active conversation about whether or not hysterectomy is something that should be considered more seriously than it has been. And of course, for younger women, there's also a conversation going on about whether or not salpingectomy, just removing the tubes alone, could be a reasonable bridge to prevention until they go through natural menopause. There's some evidence that many of the cancers that we are currently calling ovarian cancer may have started in the fallopian tubes, and that in theory, by removing the fallopian tubes, you could decrease the risk. Still needs to be proven because we don't know when the cells jump from the fallopian tubes to the ovaries. But this is certainly something that's becoming an increasing part of practice, even in the absence of clear data proving safety. Prostate cancer is a big deal now, and it's becoming even better understood. Between 25 and 30% of men with BRCA2 mutations in particular will get prostate cancer, and they appear to be at increased risk for more aggressive and potentially life-threatening disease. Male breast cancer is still relatively uncommon. And there's some controversy about the most appropriate way to screen and manage those men. We at Memorial generally just advise breast awareness and don't necessarily do specific radiographic screening. Other places do. Pancreas cancer is another part of the spectrum that's becoming increasingly well understood. The risks are fortunately quite low because it's a obviously pretty severe disease, but we don't have any great screening for that. But individuals with BRCA-associated pancreas cancer do seem to be responding to both platinum-based therapies and PARP inhibitors, and so it may have therapeutic implications. The issue of colon cancer risk has been going back and forth. Back when BRCA1 and BRCA2 were first identified, there were some early studies suggesting a mild increase in colon cancer risk. Others did not confirm that, and so the issue of increased colon cancer risk got de-emphasized. There's been a study recently that raised the issue again. Fortunately, the risk, if it exists at all, does not seem to be any different than having a first-degree relative affected. And so the most one would do would be early colonoscopy, starting, for instance, at age 40 instead of 50. But it hasn't yet made it into the guidelines as to whether or not that's necessary. Certainly, if you have a family history of colon cancer or colon polyps in a close relative, then that's an indication for early colonoscopy anyway, and the BRCA mutation itself isn't necessarily something that should drive it. Now, the question that comes up, of course, is whether or not there are factors that modify risk. This is something that we've been struggling with. it doesn't appear that the traditional risk factors have a consistent effect. So traditional reproductive factors like age at which women begin or end their menstrual cycles, age at which they have their first child, or number of children have not had consistent effect, and there are no clear environmental modifiers, although certainly things like alcohol and tobacco every now and then come up. There are genetic background modifiers. There are common genetic variations which are not really mutations. They're just reflections of our normal genetic differences that do appear to have some influence. And it may be that in the relatively near future we'll be able to offer BRCA mutation carriers an additional test that helps delineate that genetic background a little bit more clearly and perhaps give more precise and individualized risk assessments. Whether or not those are going to differentiate people's risk enough to make a difference for their clinical decision making remains to be seen, but it certainly is potential for giving somebody a little bit more information than that, well, your risk is somewhere between 50 and 90%. Non-surgical interventions for BRCA risks are things that people have been looking at very carefully, and unfortunately so far we don't have any good ones other than oral contraceptives, which do appear to decrease ovarian cancer risk. But since most women don't get their risk decreased back to the population risk, it still doesn't obviate the need for surgery or the potential benefit of surgery. The effect on breast cancer risk is unclear, but since it's unclear, it's likely to be very limited. Early menopause, we've been telling folks for a long time, decreases their breast cancer risk. There were a number of studies done suggesting that preventive oophorectomy in premenopausal women also decreased their breast cancer risk. The risk was greater for women with BRCA2 mutations than BRCA1 mutations because women with BRCA2 mutations are more likely to get estrogen receptor positive disease, which is most susceptible to that kind of a modulation. But there's some new data that suggests the benefit may be more limited than we thought, unfortunately. And longer-term follow-up now of prospective cohorts is important to try to hammer this down a little bit more tightly. And the impact of so-called chemoprevention or pharmacologic risk reduction with tamoxifen, raloxifene, or aromatase inhibitors remains unclear, although certainly for subsets of postmenopausal women it's not an unreasonable thing to try because most of these are reasonably innocuous, particularly raloxifene, and if it does have a benefit, it's potentially a win with relatively little cost. Now, BRCA1 and BRCA2 are not the whole story, and we've known this for a long, long time. You know, from back in the original studies that were done with very high-risk families used to identify BRCA1 and BRCA2, these are families with 4 or more cases of breast cancer before the age of 50, with or without ovarian cancer, with or without male breast cancer. Only about 2/3 of those were tied to BRCA1 and BRCA2, and fully a third were unexplained. And if you go to families with less dramatic family histories, the proportion that are explained by BRCA1 and BRCA2 becomes even lower. There are a number of other genes that we call high-penetrance genes that cause that autosomal dominant type of predisposition syndrome that are tied to breast cancer risk. One of them is a gene called P10. It causes a syndrome called Cowden syndrome, which is a fairly broad cancer predisposition syndrome. Breast cancer, it causes an increased risk of uterine cancer, potentially kidney cancer, and it has a number of characteristic physical findings, including a large head, these very unusual findings on the gums, these things called tricholomomas, which are a particular type of cutaneous finding, particularly on the face. You can see all these sort of nodular papular lesions. It's called papillomatous tongue. The tongue has all these almost warty types of protrusions. And then I don't know if you can see them particularly well, but these pits on the palms and the soles. It's a rare syndrome. It is rarely found in people who don't. These mutations are rarely found in people who don't have the characteristic physical findings. But women who do have mutations in these genes are at substantially increased risk for breast cancer and need appropriate management and monitoring. There's another syndrome called Yeager syndrome, which is a gastrointestinal polyp syndrome. It presents with a particular type of GI polyps, and in childhood or young adulthood, individuals with mutations in this gene, STK11, STK11, have characteristic freckling around the mouth, in the armpits, and on the lips. This usually presents because of bleeding or polyps. Sometimes it'll present in infancy with what's called intussusception, where the bowel basically telescopes on itself around a polyp. And it's associated with an increased breast cancer risk as well as an increased risk of a number of other types of cancers, usually quite easily recognized because of the characteristic pigmentation in the polyps. Li-Fraumeni syndrome is a tough syndrome. It doesn't have any characteristic physical findings, but the family histories of individuals with Li-Fraumeni are quite dramatic. Multiple cases of breast cancer, often very early onset. And unlike the other syndromes, this is associated with a significant risk of childhood disorders, particularly brain tumors, leukemia, adrenocortical carcinoma, and sarcomas, which are tumors of either bone or soft tissue. For again, a long time, we've thought that this was relatively easily recognizable. These families tended to be rather unsubtle when they were presenting. It's a more common cause of very early onset breast cancer before the age of 30 than BRCA1 and BRCA2 are. But increasingly now with panel testing, which we'll talk a little bit more about later, people are getting P53 testing with less characteristic family histories, and we're finding mutations. So the reason that this hasn't been sought very aggressively is that a lot of people who have P53 mutations, quite frankly, don't want to learn about them because of the quite dramatic implications for their families and also potentially the development of diseases for which there's no good screening, like brain cancer. Hereditary diffuse gastric cancer is due to mutations in a gene called CDH1. This was first identified because of families like this, where there are multiple cases of very early onset stomach cancer. Breast cancer is seen in this, particular lobular breast cancers are seen in this syndrome. And if individuals don't develop stomach cancer, they may have a 40 to 50% risk of developing a lobular breast cancer. Again, this is another syndrome like Li-Fraumeni that we originally thought was easily recognizable, that lots and lots of people who had this syndrome would have family histories that look like this. But in the era of panel testing, we've unfortunately been identifying CDH1 mutations in people who don't have any family history of stomach cancer. And that's a very challenging situation because the standard recommendation for a mutation carrier in a family like this is to have his or her stomach removed at a relatively early age. And that's a very difficult thing to consider if you come from a family that doesn't have this type of pattern of stomach cancer within it. So CDH1 testing has been a big challenge and one of the biggest challenges of panel testing. So all of these, P53, P10, CDH1, and STK11, are rare. In aggregate, we find these in probably only 1 in 200 people who are undergoing genetic testing and are BRCA negative. So we'll pick up BRCA mutations in 3 to 4%, sometimes higher, depending on how careful your selection criteria are, of people who present for evaluation of a family history of breast or ovarian cancer. You find these in much, much fewer patients, and almost always, although not uniformly, almost always, you'll be able to look at the family history and suspect one of these mutations. The predispositions for all of them, including BRCA1, BRCA2, are increased risk for multiple different cancer sites. And so learning about a mutation is important because it helps guide you in potentially screening not just for the breast cancer or the ovarian cancer that one presented with, but also for other things that you might not have thought about. An important point is that if you find one of these mutations in a family, the people who don't have that mutation are probably pretty much back to the risk of the general population. And so in this setting, so-called true negative results are meaningful and very, very helpful. But these are what we call rare variants of high penetrance, which are very high relative risks, which means risk compared to the general population, but they're very rare. Allele frequency, this is more common, this is less common, this is higher risk, this is lower risk. And over the years, we've learned more about what's called the genetic architecture of breast cancer risk, and this is a very, very small part of the pie. In the general population, by far the bigger part of the pie is taken up by that common variant, those genetic background factors that I mentioned earlier as modifying the risk in the BRCA carriers. They modify the risk in the BRCA carriers, but they also modify risk in women who are in the general population. And there are now some tests. There are over 90 areas in the genetic code where different variations can influence risk, individually to a very small degree, but in aggregate potentially to a substantial degree. So much of the variation in risk in the population is due to this, the common variants, not this, the rare variants like BRCA1 and BRCA2. And then in the middle, we have variants that are rare, but are not as strongly predisposing as BRCA1 and BRCA2. And there's no broadly accepted definition of what's moderate and what's high, but generally the field is converging upon considering something that has a risk of 2 times to 5 times the general population risk to be moderate, and something that's more than 5 times to be high. But that's arbitrary. It's just a way of dividing things up. There's a whole alphabet soup of moderate penetrance genes that increase the risk for breast, increase the risk to a lesser degree for ovary, and we'll talk about that more in a second. Overall, in the era of panel testing, mutations in 1 or more of these genes have been found in about 3% of individuals who are BRCA negative or Lynch syndrome gene negative if they're coming in with colon cancer history and who are undergoing testing. So they're still individually relatively rare, but in aggregate, if you do a whole bunch of testing on a whole bunch of people coming to the clinical genetics service, you'll find a not unreasonable number of them. These have become, we've known about these genes for years, and we haven't been or weren't routinely testing for them because the clinical implications were relatively unclear. There's a couple of jargon terms in here that are worth hearing. One is clinical validity, which means understanding whether or not a mutation in a gene is or is not associated with an increased risk, and that can sometimes be controversial. You can have mutations that are not associated with increased risk. And then the other is clinical utility, which is whether or not knowing that there's a mutation in a particular gene will lead to a change in management and therefore be helpful. And so even though we knew about all those genes that I showed you on the preceding slide, we didn't go out and test people for them when they came to see us in the clinical genetics service and were negative for BRCA mutations because we didn't have a sense of how that was going to change their care. But when panel testing became available because of advances in sequencing technology and the new laboratories were now able to jump in, and this particularly occurred after the Myriad patent was negated, everybody kind of got into the game and wanted to do testing not just for BRCA1 and BRCA2, but for all of these different genes. And it became, and continues to be to some extent, an issue of my panel is bigger than your panel, and so I just put all these genes on there, even though I'm not entirely sure what they mean, because by doing so I can represent things as being comprehensive. And this was a place where there was a disconnect, and continues to be somewhat of a disconnect between what the laboratories think is a good idea both for themselves and for their marketing, and what the clinicians are able to do. And there's some controversy within the clinical, there's a lot of controversy within the clinical genetics community about the best approach. So I don't really want to go into in excruciating detail, but just to know that there is some disagreement. But what there's not disagreement about is the fact that if you do multi-gene panel testing, you're going to find stuff. And this is the aggregate results. I went and I pulled together all the published studies of multi-gene testing. Over 90,000 people have had multi-gene testing, so lets you know what the penetration of this has been. And these are the genes in which mutations have been identified in the relative frequency. So you can see, not that common. Nearly 1% of people have mutations in a gene called CHEK2. A little bit fewer have mutations in ATM, PALB2, BRIP1, And then there's a long tail of other stuff that's all of which in aggregate, each of these is less than 1 in 500 women or individuals undergoing testing. This is another way of representing it as a pie chart. Just shows you that the vast majority that we have to wrestle with are CHEK2, ATM, PALB2, and to a lesser degree BRCA1, and then there's a long tail of the other stuff. The reason that this is kind of worth looking at is you think about how long it's taken us to come to some degree of consensus on how to manage BRCA1 and BRCA2 carriers. And it's an order of magnitude more patients with BRCA1 or BRCA2 mutations than there are with mutations in any one of these genes. It's very difficult to come to consensus about management of, for instance, an MRE11 carrier or a BARD1 carrier, just because the numbers are so small. And it's going to take us a long time to be able to get the information that we need from observational studies to have robust estimates of risk and the effectiveness of interventions. So until then, all the guidance and all the recommendations are to some extent arbitrary and are derived from expert opinion and people trying to be thoughtful rather than actually hard data. This is a little bit of a busy slide, but I wanted to condense some stuff just to kind of give you some estimate of what the risks are likely to be for these genes in absolute terms. So these are now risks of developing these disorders by the age of 80. So CHEK2, which is the most common one, probably has somewhere between a 25 and 30% risk of developing breast cancer by age 80. Just for comparison, a woman who doesn't have a mutation but whose sister was diagnosed with breast cancer probably has about a 25% risk of developing breast cancer by the age of 80. So the risks that are associated with these genes are by and large much, much lower than the risks that are associated with BRCA1 and BRCA2. At least right now, we don't think that there's an increased ovarian cancer risk for CHEK2. There's been no evidence of that. There may be a very modest increase in colon cancer risk, but if there is any risk at all, it's probably less than having a parent or a sibling affected with colon cancer. So whether that's in change management is unclear. ATM is another one of the common genes. It has a perhaps slightly higher risk, but very, very marginally higher than CHEK2, probably about 30% by the age of 80. Also does not appear to have an increased ovarian cancer risk. It may be associated with an increased pancreas cancer risk since it's been observed in families with multiple cases of pancreas cancer, but in terms of numerical estimates, we don't have those yet. PALB2 is an interesting gene that perhaps is the best candidate for what we used to call BRCA3 because it does have a significantly elevated risk of around 45% on average by age 80. So now it's kind of getting up there to the lower range of where, for instance, BRCA1 or BRCA2 is. But it so far has not been clearly linked to an ovarian cancer risk. There are some studies that suggest there may be a very mild increase, but there are others that suggest not. So this is an area in development, and right now we're not considering PALB2 carriers at increased risk for ovarian cancer. They may have an increased risk of pancreas cancer since, again, PALB2 has been seen in families with pancreatic cancer, but the degree to which it's increased is unknown. Now, BRCA1, I did these in order of observation, is almost the opposite. In that for BRCA1, there's no clearly increased risk of breast cancer. This is not necessarily what's said on some of the diagnostic laboratories' guidance to their ordering physicians, but there have been some recent studies suggesting that breast cancer risk is not clearly increased for BRCA1, but it does have an ovarian cancer risk that's around 10 to 15% by the age of 80 and perhaps even a little bit higher. So the ovarian cancer risk with BRCA1 is probably around the lower range of BRCA2. NBN is interesting. Its breast cancer risk is about the same as ATM. There's no clearly increased risk of ovarian cancer, but the data for NBN is largely based upon the study of a single mutation that's relatively common in Eastern Central Europe. It's not an Ashkenazi mutation. It's more of a Slavic mutation. And all of the estimates of risk come from that mutation, and that may not be reflective of the risks for other women. BARD1 shows up not uncommonly. Again, these are in order of observation, but BARD1 has a very undefined risk of breast cancer. probably at most it's going to be similar to CHEK2, but probably not even that high overall. Although there's been some suggestion of a specifically increased risk for triple-negative breast cancer. And like PALB2, there's no clearly increased risk of ovarian cancer, although the data are still a little bit contradictory. RAD51C and RAD51D are genes that are like BRIP1, no clearly increased risk of breast cancer, although you do sometimes see it in a breast cancer or breast ovary family. But there are increased risks of ovarian cancer that are somewhere in the 5 to 15% range. Not as high as BRCA1 or BRCA2 by any stretch of the imagination, but still nonetheless significant. A couple of caveats to all of this, places where we have big knowledge gaps. There's been some suggestion that risks may be different for different mutations. So there are some variants in CHEK2. For instance, there's one variant that's very common in Poland called I157T, which seems to have substantially lower risk than the variant that's common in the rest of Northern Europe called 1100 del C or 1100 del C. So there may be variability depending on what mutation it is. This has also been observed for ATM. There's a particular mutation in ATM that's associated with risks that are as high as that of BRCA2. As I said, I've kind of hopefully made clear the risks are not well defined for some of these genes. And it's likely that the risks are significantly modified by other factors. We'll see CHEK2 families that look like BRCA families, and we'll see CHEK2 individuals who have nothing but a grandmother affected but later onset breast cancer. So in many ways, it may be helpful to think of these, especially for breast cancer, as being risk factors, not as causative genes like BRCA1 and BRCA2. And for the same reason, women are often affected later with mutations in these genes because they're not as strongly predisposing. And the family histories may not be as suggestive because somebody may easily make it through their life with a risk twofold that of the general population without developing cancer. And so it can be harder to recognize these families. The other implication from this is, unfortunately, that testing negative for a familial mutation in these genes may not be as much of a green light as testing negative for BRCA1 and BRCA2. If these are just risk factors rather than causative in and of themselves, then women may still have a substantial residual risk if they have a strong family history and test negative for one of these mutations. So I just want to emphasize this because it gets lost. These are not BRCA1 and BRCA2. And unfortunately, there is a tendency, particularly on the part of clinicians, to think that all hereditary predispositions are the same, and they're not. The risks are generally lower. There are genes that are associated with increased risk of breast cancer that are not clearly linked to increased risk of ovarian cancer. I talk to a lot of people with CHEK2 mutations who think that they need to get their ovaries out. And there are ovarian cancer genes that are not clearly linked to breast cancer. So people with BRIP1 don't necessarily need high-risk breast surveillance. The risks in younger women are generally less than BRCA1 and BRCA2, but there's a substantial family history effect. So the risks that are tied to mutations in these genes are influenced more strongly by family history than perhaps mutations in BRCA1 and BRCA2. And the point that I made earlier, individuals who test negative for family mutations in these genes may still be at significant risk if they have strong family histories. So what are we suggesting for management? There's been a lot of challenges in developing surveillance recommendations here. The National Comprehensive Cancer Network and the others have had a hard time coming to consensus just because of all this variability and this uncertainty. But we recently, a group of us recently did some calculations about risk, published it in a journal called Nature Reviews of Clinical Oncology, for those of you who are literature hounds. Just basically doing estimates of when the risks would cross certain thresholds. And we think that in the absence of a strong family history of breast cancer, the risks for these genes are greater than 20% lifetime, so it's probably reasonable to do breast MRIs and mammograms, but it's also probably reasonable to defer it until age 40 for ATM, CHEK2 mutations, and NBN mutations, still start at 30 like we do for BRCA for PALB2 just because the risk is high even though it's not as high. If there's a very significant family history of breast cancer, so if there's a close relative with early onset disease in particular, or if one just wants to target a lower threshold for initiation of screening, it wouldn't be unreasonable to start at 35 for these genes. But again, the risks for women who are under the age of 40 are not really substantially higher than the risks of the average population at age 45. So it seemed like starting at 40 would be reasonable absent a strong family history. ATM, CHEK2, and MBN don't need prophylactic oophorectomy unless there's a strong family history of ovarian cancer, and if there is, it's probably not due to the mutation in these genes. Colonoscopy should be done by family history, although if you have a CHEK2 mutation, it may not be unreasonable to think about doing a single colonoscopy at 40, but there's no need to do it more frequently. And pancreatic cancer screening is unfortunately still investigational, so for ATM, you'd try to do it on a clinical trial, and same thing for PALB2. For BRIP1, RAD51C, and RAD51D, the breast cancer screening should be driven by the family history and not by the mutation alone. Salpingo oophorectomy should be considered probably around age 45 to 50. Doesn't necessarily need to be done as young as it is in BRCA1 or even BRCA2, because the risks before the age of 50 are probably no greater than the risks of the average first-degree relative in the general population. So 45 to 50 is a reasonable age to target for salpingo oophorectomy, and also colonoscopy as per the family history. So that's the end of my presentation. The one thing I'll say about these guidelines, and I usually have a disclaimer slide, which I might have forgot to put in, is that these are kind of guidance that it's theoretical guidance derived from estimates of risk, which may change. All of these recommendations may change in light of future data, but it's at least a starting point for people to consider. All right, so I will stop there, and I guess we have about 15 minutes for questions if there's anything that you'd like me to try to address.
Thank you, Dr. Robson. There are a few questions, and although you may have answered some of them, I'll ask them anyway so that you can summarize. But first, can you define penetrance for us? You used it, and I think pretty much everyone sort of has the understanding of what it is, but if you can define it for us, that would be great.
Right, so penetrance is just the proportion of individuals who have a mutation who develop a disease. And if you just say penetrance without any other qualification, what you mean is lifetime penetrance. Lifetime is defined differently in different studies, but generally it's by age 70 or by age 80. Usually when you say penetrance, you should actually say penetrance by age blank, because that gives people a better understanding of what time frame you're talking about.
Great, thank you. So, if several members of a family tested negative for the BRCA mutation and have no known other mutations, should they be doing anything? How should they be managing this, or how should they be thinking about it? Should they be having more surveillance?
Right. So it depends on what the family history looks like. Much of the familial risk is not linked to mutations in known genes, and it may be those background factors that I showed you earlier, or it may be the other types of factors that I described in the first slide. And so there are a number of what are called empiric models, which are just models that have been derived from different studies that are used to predict the risk of breast cancer in an individual, taking into account things like their own reproductive risk factors, the family history, what kind of genetic testing has been done. And then you can take the numbers from those models and translate them into an action plan. And in the United States, if somebody has a lifetime risk or a predicted lifetime risk of more than 20% for breast cancer, they're usually eligible for breast MRI screening. I have to say that's a very low bar, because you don't even really have to have a twofold increased risk of breast cancer to get to 20%. And as a matter of fact, a woman who has never had a child or had a child late is probably going to be pretty close to 20% just because of her reproductive risk factors. But all my arguments with the threshold aside, that information can then be used to derive a plan. So if you have a family history, you may still have enough risk to justify increased screening, even if a specific mutation has not been identified.
Thank you. So on slide number 8, you showed a bunch of different cancers that were associated with the BRCA2 gene. Mm-hmm. Are there any other known predispositions for other cancers, like head and neck, for example?
Yeah. So the studies have been inconsistent, right? Those are the ones, those cancers that I showed you are the ones that have been consistently observed. There have been individual studies, particularly for BRCA2, that have every now and then shown other things like melanoma, uveal melanoma, which is melanoma of the eye, bile duct cancers, head and neck cancers. But these have floated in and out of different studies, and they have not been particularly consistent. I also would say that for most of those things, there's not particularly great screening. So uveal melanoma is something that, that's why you have a dilated eye exam every couple of years, and that should just be part of routine health care anyway. Melanoma is just skin check, which people should do anyway. Head and neck cancer, there's nothing particularly useful in terms of screening there. Although if somebody's at high risk because they're a big smoker or a big drinker, then sometimes the head and neck doctors will do an annual exam, but it's not clear that's helpful. So really, the big ones are the ones that I have on that slide, both because of the reproducibility in the different studies and because of the potential for screening or surveillance.
Thank you. Okay, so there are a bunch of different questions that I'm going to try to group together. So it seems that people are concerned about the following. If there is no BRCA mutation with or without a family history, should people be tested for the other genes that were discussed in one of the slides?
Right, the moderate penetrance genes.
Mm-hmm.
The situations, some situations, finding a mutation is going to change the management of the family. Other situations, it's not. And it's difficult to say that there's a one-size-fits-all, yes, everybody should be tested. So if there's a particular indication for testing, so let's say a woman was tested because she had triple-negative breast cancer but does not have a particularly strong family history of cancer otherwise, it's very unlikely that we're going to find anything meaningful in testing that particular woman. A woman who has a more significant family history, if she's BRCA negative, she may wind up having a mutation in one of the other genes. And then the question is, well, is that going to change anybody's management? Since one of the main reasons for doing BRCA testing, at least in breast cancer patients, is for definition of ovarian cancer risk, and most of these other breast cancer genes are not associated with ovarian cancer risk, learning about the information is not necessarily going to help her in her management. And also, since her family members may remain at risk even if they test negative, it's not necessarily going to help them. But that doesn't preclude the possibility that more information may become available in the future, and as we learn more, the information may become more helpful. But I don't think, that the alternative mutations are common enough. As I said, it's about 3% of all the BRCA negative breast cancer patients, or that our management is clear enough that it's absolutely mandatory that everybody rush back in and get incremental testing. I don't think it's unreasonable to sit down and have a conversation, and it may well turn out to be beneficial in the future. There may be people who unfortunately have advanced cancer where the information may be helpful in terms of defining treatment options, but that's a whole different group of individuals. So I think that as with everything else, it's reasonable to talk to a knowledgeable provider about the potential benefits of the information. And then if it looks like it's going to be useful, go back and get it. But we have not, I mean, just to kind of touch on this, we have not, for instance, sent out a letter to everybody in our experience in our clinic over the last 20 years who tested negative for BRCA mutations, telling them that they need to reconnect with us for incremental testing. It hasn't quite gotten to that point where I feel like we should consider it a requirement because it's so clearly beneficial to everybody.
Great, thank you. Sorry, I'm reading through some of the questions that are really kind of long, and I think are going to not allow me to ask some of them. Let's see here. So you talked about, sort of what mutations on what genes are actionable. So maybe a little bit along those lines, might treatment choices be different with and without those mutations? Does that make sense?
Treatment choices in terms of therapy, or?
Someone's already had a diagnosis and was found to have one of the mutations on one of the genes. Would that influence, might they be treated like someone with a BRCA mutation, for example?
Yeah, I mean, so obviously there's a number of different kind of arenas where treatment could be influenced. So you think about the issue of prophylactic mastectomy for the opposite breast in women who have one breast cancer, right? I mean, this is another one of the major reasons why women get BRCA testing in the setting of a new breast cancer diagnosis, is to decide whether or not to have bilateral mastectomies versus lumpectomy and radiation. The risks to the second breast associated with these genes are much, much lower than the risks associated with BRCA1 and BRCA2. So a woman with a BRCA1 or BRCA2 mutation has probably 25 to 30% risk of developing a second breast cancer on the other side in the 10 years after her first diagnosis. For these genes, it's probably closer to 10 to 12%, and those are just multiplicative estimates compared to maybe 5% to 8% for the general population. So it's not enough of a bump to automatically, or in my opinion, it shouldn't be enough of a bump to automatically indicate people to undergo bilateral mastectomy, for instance. There's no contraindication to breast conservation therapy. In the ovarian space, and also perhaps in the breast cancer space, there's no, although a lot of people think that PARP inhibitors may be useful in this setting, that hasn't yet been proven, and the studies are still being developed and need to be done. But mutations in PALB2, for instance, may confer sensitivity to PARP inhibitors. Mutations in RAD51C or BRIP1 for ovarian cancer patients may confer sensitivity to PARP inhibitors, but the studies to prove that are still pending. There are other circumstances that you can kind of think about where people may consider, is this or is this not going to change treatment? But on the basis of just risk alone, it's probably not going to have a major effect based on what we know now.
Thank you. Okay, so there are some people who are listening who have not yet had any genetic testing and may or may not have been diagnosed with a disease, and they're concerned about privacy issues regarding genetic testing. Mm-hmm. Can you speak to that a little bit?
Yeah, it's been something that's been around and has been a concern from the very beginning. What I can say is that at least right now there is no evidence that I'm aware of that there's any systematic discrimination against people who have been found to have genetic alterations, mutations. There is reasonably good but not perfect protection against insurance discrimination, both through the Genetic Information Non-Discrimination Act and also through the Affordable Care Act. But it is imperfect. There are certainly situations where GINA does not apply. There is reasonable protection against employment discrimination through the American Disabilities Act and the EEOC. There is really not much in the way of protection against discrimination in the area of life insurance, underwriting, consideration for financial products like mortgages, and there is also no way of predicting the future. So it is, I guess, theoretically possible that everything could change on a dime in the future. But that's not the tenor of the way things are going in terms of people have, including payers, have a belief in the power of genetics for prevention and actually improvement in health rather than trying to use it to carve people out of their underwriting pools. But at the end of the day, all one can say is it hasn't been a systematic problem, although there are individual cases that I've heard of where people believe that the reason that they had some type of adverse event was because of their genetic testing, but it's not systematic that I can tell. It is in many arenas subject to some legal umbrellas, but at the end of the day, you can't prove a negative forever. And one just has to make one's own decision whether a theoretical risk, which is immeasurable because it is so rare, outweighs the potential benefit of getting the information. And that's just an individual call.
Well, thank you. I think that's all the time that we have for questions. Thank you so much.
My pleasure.
Savannah?
Yes, thank you so much, Dr. Robson. It was a really informative program, and I also want to thank all of our participants. Since I have everybody here interested in genetic testing, I wanted to let you know about one other program that we're having in September called Talking with Your Family About Hereditary Cancer. We have a psychologist, Dr. Karen Hurley. She's a psychologist, and she's going to be speaking about having these kinds of difficult conversations with your family. We're going to share strategies for managing the sources of conflict that surround genetic testing within families. We're going to talk about whether or not to pursue testing, reaching out to at-risk relatives, and the stress that can arise from the hereditary disease. So I know that some of you had questions about that, and that would be a good webinar to, I'm sorry, this is an in-person event. Sorry about that. So it's on our website, sharecancersupport.org. It's on September 29th from 6 to 7:30 p.m. Just check our website. Also, I just wanted to ask everybody, please, if you could, to take a moment to fill out the survey at the end of the webinar. In order to fill that survey out, you need to click, exit, and leave the webinar. And then the survey will pop up on your window. It really helps us to make sure that we can continue to provide the programs that are of interest to you. It will just take a minute. So thank you again to Dr. Robson and to all the participants.
Thank you so much.
Thank you.